Good morning. Is it morning, still afternoon? Thank you for attending this talk. You're going to have to be patient with me. It's my first time doing PowerPoint. Does it work? Yeah. And also giving a proper academic lecture. So, as we can read, low back pain, leading cause of disability, and top musculoskeletal condition. So for me, when I started practicing, I had these patients, one after the other, been to different chiropractors, physios, MDs, had an X-ray, but they had very similar signs and symptoms. And these patients would end up with specialists. They would have X-rays, well, if they hadn't, they'd have MRIs, CAT scans, myelograms, blood tests, urine tests. And in my opinion, of this type of patient, not a diagnosis that I was happy with. So there were many things, they were told many things, which I'm not going to go into, but in my opinion, not diagnostic. So I started reading medical research, and when I say medical research, internet, papers, China, India, Japan, anywhere. I just read anything I could on medical research to try and understand if there was an answer to this type of patient or not. So for this talk, I'm going to divide back pain into two groups, specific and non-specific. So it's quite a standard way. So specific back pain is 10 to 20% of back pain. Non-specific is 80 to 90%. So just quickly going through specific back pain, this is pretty much what you guys and girls should know about. So specific back pain, soft tissue examples, muscle strain, ligament sprain, lumbar instability, spondylosis, spondylolisthesis, retrolisthesis, all that movement stuff. Then, other examples of specific back pain, rheumatoid arthritis, ankylosing spondylitis, spinal stenosis, so serious stuff. And all of those come with their clinical testing, signs and symptoms, and you can work it out pretty much that it is rheumatoid arthritis causing the pain. There's no debate about it. And then with specific back pain, we have the red flag conditions, which are like fractures, cancer, infection, and a few others. So I'm just going through this quickly. So the red flag signs that are typically concerning: weight loss, persistent fever, and neurological function that gets worse. Cauda equina, saddle anesthesia are obviously getting severe. And those patients you would obviously refer out to a specialist. So that is specific back pain. So X-rays, MRIs, blood tests, urine tests, spectacular. They work that stuff out. But non-specific back pain. So how good are X-rays? They're actually no good. So if you take an X-ray of somebody with lower back pain, you see a thin disc, a vertebra that's a retrolisthesis, whatever, lipping and spurring, lumbarization. Do you know if that is the cause of the pain? Or is that just a finding? What is your evidence that that is the cause of pain? If you took that X-ray to another chiropractor or radiologist, ask them one simple question: is this patient in pain or not, by looking at the X-ray? Yeah. In any case, that's X-rays. MRIs. MRIs are not... Oh, geez, I didn't even realize I've got this in front of me. That makes it easier. No. This has become a lot less stressful suddenly. So MRIs, how good are they? Well, if 91% of people have disc protrusion with no pain, disc protrusions, annular tears, high numbers, so MRIs, many studies have found, and probably in this room, probably a third of you got a disc bulge or herniation without any pain. So how good is an MRI? So quite swak. So what is an acceptable scientific diagnostic method for non-specific back pain? So this was also called mechanical back pain. And mechanical back pain was taught to be unidentifiable and thus undiagnosable. But as you see there, 91% of all non-specific back pain can be diagnosed now. So what are the two tests? There are two tests. So the first test is to see whether the disc itself is the cause of pain. There's the disc. Not outside it. Is the disc the cause of pain? So, can you all hear me if I'm talking like this?
People online might not hear you.
Oh, so good. Okay, so provocative discography works something like this. This is to assess which disc is causing pain. So the specialist will inject a contrast into, say, L3 disc. How are you doing, patient? Nothing wrong. Inject into L4. How are you doing, patient? Nothing. Patient screams with pain. Provocative. So your first bit of information, you have now found the cause of pain. That disc is causing pain. And then they put in the contrast, and then they do a CT scan. That then informs them about the damage inside the disc. So that works out whether the disc itself is the cause of the pain. Not externally, internally. The next test is dual diagnostic blocks. So in this test, the test is to evaluate if the specialist can remove the pain. So the patient has pain. And dual being two, so the first is an injection of lidocaine, a small amount of lidocaine, which is a local anesthetic. And they will inject into the facet joints and into the SI joints, and then into the facet joints one at a time. So the idea with this is that the specialist would probably sort of know which area, and if they were thinking it was SI, they'd start there, or if it was facet joint, L5 facet joint. So they inject into, say, L4 facet joint. How are you doing, patient? Still sore. L5 facet joint on the right, still sore. Right SI joint, still sore. Go to the other side. Left SI joint, still sore. L5 facet joint on the left. How are you doing? Pain's gone. So now he's found the pain. I'm going to point my thing at you guys there. If you don't keep my little screen on there, it's like my blankie there. In any case, so they find the cause of pain by removing the pain, and by aggravating the pain. So what did they work out? And these things have been done over and over by specialists. So the causes of non-specific back pain, making up that 91%, 31 facet joint, 18% sacroiliac joint, and the winner at 42%, internal disc disruption. So if you didn't know, you now know why internal disc disruption is the #1 cause of back pain, with scientific evidence. So this is what this talk is this condition that is not well known. So that's De Palma, that, okay, well, there it's working. In any case, the science was done by De Palma in part of this. And if there are questions, the timings run short here, so afterwards, write down questions for me. And I'd like, if there are people that would like to know more about this, we just meet together and you just ask me questions. So this is a lot to get an understanding in one session in 30 minutes. So what else did these researchers work out for us? With dual diagnostic blocks and provocative discography. Age is a predictor. So if you're 43 years old with lower back pain, 70% chance your back pain is IDD. So just knowing a simple number and an age. So if you're 55 years old, probability of IDD diminishes dramatically. If you're older, the likelihood is 60 or 70, it is more facet or SI joint. And I would advise you go read these papers, or I will give the papers to you people to read, whoever's actually interested in this. Then the next thing is where it is tender in your spine. So if you have spinous process tenderness in your lower lumbar, you probably have IDD. If it's paramidline, so 1 finger breadth from the spinous process, probably facet or SI joint. Okay, so we've now worked out that the primary cause of back pain is this disc. And this is internal. This is not outside. That's herniation. That is external disc disruption. We are talking internally. So we need to just understand, just go back and think about the disc anatomy. So we have a vertebra. Between the vertebra and the disc is an end plate. Between the two vertebrae, you make up a disc. So, it's not the 1st of April, is it? Okay, some disc anatomy. So, the disc, classically shock absorber, cushion, whatever. We've given this thing a very bad amount of time academically. We should start looking at this thing a bit more carefully. So you have got 15 to 25 annular rings that holds the nucleus in the middle. And you have got the sinovertebral nerve coming off the spinal nerve. It backtracks, and it has nociception sensitivity into the outer third of the disc. And this nerve was found by none other than Luschka in 1850. So we've known about it, but we forgot about it. So blood supply to the disc, as you can see by that furthest image, is blood vessels to the end plate. A little bit of blood from the side, but that interface there, that end plate, is the interface between nutrient flow in and out. So the disc works via osmosis, water out, waste out. water in, nutrients in. It's a closed hydraulic system, a pump mechanism. And while you're all sitting there dead still, your disc is not pumping, you're just drying it out. So, how do things go wrong with this disc? Trauma, genetics is always one of them, and then loss of nutrient, that osmotic function somehow stops. So that study there in 95 was the study that proved, so this study, I think it was 39% of all back pain is internal disc disruption. The other study by De Palma was 42%, and there have been several studies. So they're 39, 42. So it's now generally accepted that all lower back pain, 40% of it is internal disc disruption. And another name for internal disc disruption is discogenic pain. So discogenic pain, internal disc disruption is the same thing. So that on the right is the modified Dallas discogram. So you start with a disc that is happy in the middle, the nucleus in the middle. And then slowly, a fissure starts. So there's an injury at the disc. The fissure starts moving outwards towards the outside. So there's damage that has occurred at the nucleus. There's damage occurring as it breaks one lamellae after the other, going out further and further as it progresses. But as this cell death is occurring in this anaerobic environment, you're developing an inflammatory cytokinase. And these are, for example, necrosis factor alpha, interleukin, and nerve growth factor, vicious cytokinase. So when that fissure reaches 2/3 way out, it makes contact with the sinovertebral nerve. Exquisite pain. There's now a combination of things going on. You've got this inflammatory cytokinase, you've got a hypermobile joint because it's lost its strength, the lamellae. And another factor is that fissure, the sinovertebral starts to grow back up along the fissure. This is called nerve ingrowth. It can go right up to the center of the disc. So this is a very sensitive nerve reaching right into the middle of the disc. So you've got a combination now of inflammatory cytokinase, a hypersensitive nerve, and mechanical pressure. And I don't know if any of you have ever read Chiro Geek, or if you haven't, I would advise you do. So Professor Gillard is in America at Palmer West or whatever. So he calls this disc wired for pain. And I'm using his quote on that. It's a good word. So this disc, now in this state, can give you mechanical pain, chemical pain, or both together, and it can refer into your legs. So the pain from your disc is called somatic pain. The pain into your legs is called sclerotomal referral. But this disc hasn't stopped yet with giving you pain. When it is sitting there, say at grade 4, those inflammatory cytokines can cross out, leak out, and infiltrate the spinal nerve, causing reticulitis. So that is irritation of the spinal nerve. So now you have got, and that can go down into the legs, causing dermatomal irritation. So that disc there is giving you two forms of leg pain, two forms of back pain from within the disc, and possibly back pain from where it's irritating the spinal nerve. Perfect looking X-ray, perfect looking MRI. So what happens to these patients that have this? They go from chiropractor to physio to whatever, eventually to the specialist. They do the MRI, CT scans, myelograms, CAT scans, whatever. If the specialist is not aware of this condition, they miss it. So that patient is told that they're overreacting with the pain. Maybe they're malingering. The doctor might think they're malingering, not say anything, might give it some disorder, whatever, all these peripheral neuropathy, whatever, some word that fits with this condition. But that's not diagnostic. This patient is distraught, anxious, getting depressed, and nobody is giving them any time of day, emotionally and functionally. They start using medication because that's all they can do. They are living in pain, or they start smoking Zol or drinking or whatever, because nothing else is helping. So if that last author, Nikolai Bogduk, on that seminal paper of 95, now some call him the god of anatomy. He's won a Volvo Prize. If you want to look up this oak's pedigree, he's from Newcastle, Australia. He's got a pedigree like nothing else. So, I forgot about this. So internal disc disruption has two types there's two types. Internal annular disruption, and as you can see, this is going into the annular, and the other type is internal end plate disruption. That one goes up or it can go down. It doesn't really matter which way it goes. The nerve density is the same. So the internal end plate disruption was found around about 2010 by Professor Bao from Singapore. In any case, somebody wants to know exact stuff about that, I'll tell them. So just to come back, this is what Professor Nikolai Bogduk has to say about why I pursue discogenic pain. The fundamental reason I pursue the diagnosis of discogenic pain is that patients have no other valid alternative. Patients with chronic back pain get caught in a circus. They are told there's nothing wrong with them medically, or they are told something fallacious, such as once did have nociception, but that has now ceased, and now they only have a memory of that pain. Under those conditions, medical treatment will not help, and the only prospect of treatment is behavioral and physical rehabilitation. But that treatment does not work. The patients still have pain. Yet again, they are told there's nothing wrong. They failed rehabilitation. And the only recourse is to repeat it, start again. So that was 2009. This is a more recent paper. Approximately 40% of patients with persistent symptoms of chronic lower back pain have evidence of internal disc disruption. If back symptoms persist beyond 3 months, the vast majority of patients with definitive imaging evidence of internal disc disruption do not have a good prognosis for recovery with conservative management alone. These patients face possible opioid dependency, or major surgery. So this information has made a huge difference to how I see lower back pain. And it's fundamentally changed that our way I practice. And for me, as chiropractors, I see a great opportunity for us to help these patients. I think chiropractic is very well suited for this. So let us just think about clinical application. So if we consider what I've just said, lower back pain, patient comes in, first thing we do, work out if they've got specific back pain or non-specific back pain. If they've got specific back pain, do X-rays, MRIs, do the blood test, or send them to a neurosurgeon or whatever. If it is non-specific, which is the common one, which is the one that we are mostly seeing, if the patient is older, SI facet joint. If they have paramidline sensitivity, SI facet joint. If the patient is younger, spinous process tenderness, IDD. So you've now got a starting point. But there's a parallel that I need to draw up. So, disc herniation, external disc disruption. Internal disc disruption, very close to that. So, how do we differentiate between IDD and herniation in the early stages? Because they are very similar. So the signs and symptoms are similar. Antalgia, loss of range of motion, pain with a cough test, can't sit, pain with seated straight leg raise, pain with supine straight leg raise, referral, pain into the legs, etc., etc. So how do we differentiate? So IDD, the pain is coming from within the disc, somatic pain from within the disc. That is then referring possibly into the legs. And that is called sclerotomal pain distribution patterns. But this does not cause loss of function. So the patient is in pain, feels weak, but is not actually weak. So what happens with the herniation? The hernia is pushing against the nerve, causing radiculitis. Radiculitis ends up with dermatomal pain distribution patterns. And as the radiculitis or pressure gets worse, loss of function. Patellar reflex gets weaker. Patient can't heel or toe walk anymore. And this should already be enough to get you anxious and sending out. Paralysis next. Cord equina, so that's loss of control. Saddle anesthesia, that patient should have been out of your practice long ago. But in any case, that's the difference between the two. So at this point, I just want to reevaluate provocative discography. This is a horrific, it is the only diagnostic test to prove IDD, but it's hectic. It's expensive, it's mursel, and the worst part of it, when you put a needle into a closed hydraulic system, you weaken it, you set it up for a hernia, and it might cause an infection amongst other things. So it is a test that you do only And these researchers that did this did it on only patients that had absolutely nothing wrong with them, and there was no other alternative. So, does IDD demand a paradigm shift? Should we be taking this thing a little bit more seriously? Should we be looking at this a bit more seriously? So those 4 organizations on the right, the American Medical Association, Physiopedia, British Chiropractic Association, World Health Organization, and last night I did the American Chiropractic Association. So I searched these and just did a basic question: what are the most common causes of back pain? And those 4 plus AMA, not one of them does discogenic pain or IDD make the list. So as chiropractors, shouldn't we be trying to identify this thing? We can't do provocative discography, we don't want to do it. But if we got to know the history of this, the signs and symptoms, maybe the tests, maybe we just applied our minds a bit, we could maybe clinically work this thing out in our practices. Then in practice, if we could take the pressure off the disc, allow the nucleus to centralize, allow the fissure to start closing slowly, allow osmotic function to increase, isn't there potential for healing? Will that, when all those things happen, will that sinovertebral nerve not calm down a bit and make that poor patient's life just a little bit more pleasant, and also not as anxious because they can understand what the hell's going on with them? Then we can help them clinically, and then we need to explain a lifestyle where they don't do this to their disc. Walk, lean, lie down. Don't run. Don't do weights. Do whatever. But we need to manage this. Thank you.